Hi, this is Dr. Edney. I'm going to go through how to view a prostate MRI. So here we can see all of our sequences laid out for the prostate MR, and I think these are changing as we speak as far as our protocols, but we do have some version of a coronal, sagittal, and T2 and axial T2 sequences, diffusion weighted imaging, a T1 weighted image, and post-contrast. So the first thing that I do when I open a prostate is go up to the toolbar and click Send. We want to send active study, and we're going to send it to Dynacad Mammo to do our post-processing. So we click Send One Study, and this will automatically close. And while that's sending, we can start looking at our images. So the Coronal T2 is our biggest field of view. We can start with that as an overview. And I like to save the prostate for last, since that's the focus of the exam. I'm going to start out by looking at everything else that I might otherwise forget. So we can see the inferior portion of both kidneys. We can see there's a small cyst on the right kidney. We can see the urinary bladder, the genital organs. There's our prostate, and we'll follow the rectum, the sigmoid colon, to the ascending colon. We can see the descending colon. Oftentimes the terminal ileum and the appendix are visible, and the lower abdominal and pelvic small bowel loops. We can also see the major pelvic flow voids, bone marrow structures, and just make sure there are no abnormalities in those regions. So then we switch to our sagittal and axial T2 high resolution, and the axial is really our workhorse for this exam. So focusing on the prostate gland, we have the peripheral zone, which is peripheral in location, normally has homogeneous T2 hyperintense signal, and then the transition zone, which is central. It's separated by a small T2 dark capsule from the peripheral zone. It can be a variable size. In a patient that has BPH, you may see mostly transition zone, and this peripheral zone will be compressed and small from the BPH. So I like to just focus on first the peripheral zone and then the transition zone and go through all portions of the prostate gland. So most inferiorly we have the apex. At this location it's almost all peripheral zone, and we just have mostly urethra going through the transition zone. As we move up superiorly we have the mid-gland, and the most superior portion of the prostate is the base. And above that we get into the seminal vesicles, these T2 hyperintense serpiginous structures, which should look symmetric. This portion can often be confusing. At the base of the prostate gland, there's this symmetric T2 hypointense signal, and this is thickening of the surgical capsule as the prostate gland transitions into the seminal vesicles. This is normal as long as it's symmetric. It kind of has this heart shape again, and it should not restrict diffusion. So then if we see any abnormalities on T2, we can cross-reference with the sagittal, make sure we don't have volume averaging or some other artifact. So here the most glaring abnormality to me is this T2 hypointense lesion in the right posterolateral peripheral zone at the mid-gland. And when we come over to the sagittal, we can see that this persists in sagittal, and this is a real lesion. So we want to follow our PIRADS criteria to derive a score based on the dominant sequence parameters for each location in the prostate. So for the peripheral zone, that's going to be diffusion and ADC, and for the transition zone, that's going to be T2. The main role of diffusion in the transition zone is to potentially upgrade a lesion from a PIRADS 3 to a PIRADS 4. And the main role of T2 in the peripheral zone, which we're doing now, is to evaluate the morphology and shape of a lesion, and then later to look for extraprostatic extension or neurovascular bundle involvement. We also want to differentiate organ-confined disease, which is a stage T2 or less, to disease which is not confined to the prostate, which is going to be stage T3 or more. We also especially want to assess the anterior fibromuscular stroma, the anterior gland, and the periurethral apex, because these are areas that are blind to physical exam from the urologist and they're also blind usually to systematic prostate biopsy. So in this case, we think we have a lesion in the right peripheral zone at the mid-gland. Now it's time to look at diffusion. I usually use either the B1400 or the B2000, depending on how they turn out. And we put the ADC on this side. I usually have to window this down quite a ways. And we can look at it with the T2 in another window. And here we see there's that lesion in the right peripheral zone at the mid-gland. It shows marked restricted diffusion, corresponding low signal on ADC. So given its size and imaging features, this would be the PIRADS 4 lesion. Of note, there are also two other lesions you may have noticed when I was scrolling through in the left peripheral zone at the apex to mid-gland. These also both restrict diffusion, and these would be PIRADS 4 as well. So lastly, we have our post-contrast. And sometimes this comes down with the images out of order. In this case, it is correct, but if it's out of order, I go up to my toolbar, click Sort Images, and sort by acquisition time, and that will give you a temporal sequence with the contrast injection, before injection and after injection. And here we're just making a binary decision. Is that lesion enhancing or is it not enhancing? And if it has early focal enhancement, a lesion in the peripheral zone can be upgraded from a 3 to a 4. So I think that lesion in the right peripheral zone does show early contrast enhancement here, but it's not going to change our PIRADS score in this case. Those other lesions, I'm not sure. I wouldn't say that they show early enhancement, definitely. And finally, extraprostatic extension is assessed by looking at specific features. So we want to look for capsule irregularity. We should see this thin T2 hypointense line, which is the capsule surrounding the entire prostate, and that looks intact. If a tumor contacts the prostate capsule by a length of more than 1 centimeter, I say we can't exclude microscopic extracapsular extension. In this case, the capsule is intact and that length of contact is less than 1 centimeter. Then we also look at the neurovascular bundles, which are sometimes difficult to see, but are these kind of cluster of dots below the seminal vesicles along the posterior part of the prostate gland. And we would suggest tumor involvement if the tumor directly extends into the neurovascular bundles, or if we have tethering or loss of the symmetry of the rectoprostatic angle. In this case, we see nice symmetric fat all around the rectum, and the neurovascular bundles are surrounded by fat and look normal. So now I'm going to switch into DynaCAD to show you the post-processing part of this exam. On my screen it shows up with these 4 boxes. It shows our Axial T2 high resolution in blue, and this is really a key part of using DynaCAD. You need to make sure that the Axial T2 high resolution is the sequence in blue, because when we go to gland segment, which is our next step, that is going to be the sequence that it pulls the prostate volume from, and that's what the urologist needs in order to do a fusion biopsy. Just the way their software works, they cannot kind of merge with our data unless we have the Axial T2 as our source sequence. So in the case that it pulls up a Sagittal or some other sequence here, you can right-click on the blue, select reference series, and select what you want. So here it's already correct. And draws a line around the prostate, and we can adjust this if we think that the line is off. Usually it needs some degree of adjustment, and we just scroll through and make sure it looks like it decently captures the entire prostate gland. Especially if there's a lesion, we want to make sure that what we're thinking as a lesion is included in the prostate volume. Once it looks good, we can click Save and Approve. Approve will automatically save as well. And then it gives us our prostate volume here, 35.5 cc's. So a normal prostate should be less than 30, so this is an enlarged prostate gland. And it gives us the 3-dimensional measurements here. At this point, we can close this window. And now, still working with our Axial T2 primarily, we want to right-click, click Prostate Location. So it'll zoom in and give us the borders that we've just delineated. And then we want to right click again and say freehand ROI, and we're going to draw a border around what we're calling our lesion. Once we draw it, we can right click on ROI1. We'll say edit, make 3D ROI. And then with our middle scroll bar, we can scroll up and down and draw again around what we think is the lesion. Just for the purposes of demonstration, I'll stop here with 2 slices, right click and edit. And this gives us our lesion volume, our lesion measurements. Right click again, and we can label this as lesion 1. Right click again, and we can edit PIRADS info. You can fill all of these out, but I usually just skip to the overall level of suspicion. Say we're calling this the PIRADS 4. And that's it. You can do the same with those other 2 lesions. I'll stop there. After you do all that work, you want to make sure the annotations are saved. And then a bonus step, but the urologists really like this, is to right click and say create movie. Once you're all done, you're going to change the spatial images capture to all. Click DICOM SC. This takes just a minute to save. Say OK. Close. It takes maybe 15 seconds until that shows up. Under this send bar, you click the drop down arrow, and it comes up as this Dynacad Cine Loop SC. You can check only that. Make sure that this top destination says store packs, and click send. So this will send that movie scrolling through with your lesions marked to McKesson, so that the urologist can clearly see what you're calling lesion 1, 2, 3, what the volumes are. It makes it very clear for other radiologists who may be presenting this case in tumor board too, especially in cases with multiple lesions.